Welcome everyone to the very first Australasian Type 1 Diabetes Immunotherapy Collaborative Town Hall Forum. It's really a privilege to be welcoming this panel. But before I do, in the spirit of reconciliation, ATIC acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respect to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples and other Indigenous peoples present today. So I've been tasked with sharing a little bit about what ATIC is all about, telling you a bit about immunotherapy and touching on some of the clinical trials involved. And then I will introduce this amazing panel I have here and open the floor up for questions. So a bit of housekeeping. Guests can log their questions using the chat. So it sounds like you're better off using the Q&A than the actual chat function. It will be only apparently the identity will be seen by us, the panelists, but the questions will be able to be viewed by all of them. The session is being recorded and will be available on the website in the week following the event, along with a Q&A document based on questions raised during the discussion. So if we haven't been able to get to all the questions in the time provided, we will ensure the Q&A document includes a response. Thanks, Graham, for your question already. The session should close after an hour. So we hope to finish by 8 o'clock. So I'm just going to spend the first 5 minutes or so sharing my screen. Okay. So what is ATIC? ATIC is the Australasian Type 1 Diabetes Immunotherapy Collaborative, which brings together researchers, clinicians and advocates to identify and create type 1 diabetes immunotherapy clinical trial opportunities. It's supported by JDRF Australia and led by St Vincent's Institute of Medical Research in Melbourne. As you can see, ATIC involves multiple major type 1 diabetes centres across Australia and New Zealand. And ATIC's chair is Professor Tom Kay, the director of St Vincent's Institute, who we have here with us tonight, and the lead investigator is Associate Professor John Wentworth from the Royal Melbourne Hospital, also on the panel. Now, of course, it's not just those two who are doing all the work. Core to ATIC's success is involvement of the broad type 1 diabetes community. So there's an extensive network of adult and pediatric endocrinologists, immunologists, clinical trial leaders, clinicians, educators, and national and international research groups. And here's just those on the steering committee, as well as those who actually help to make this whole thing run smoothly as well. And of course, front and center are the people living with the condition, their families and advocates. So we're excited to have also recently established our community engagement panel. The Deputy Chair, Fiona, is with us tonight as well, through whom we will receive feedback and input into the many parts of ATIC's work. So for more information or current clinical trial opportunities, you can visit the website atic.svi.edu.au. We've got Twitter, Facebook, LinkedIn. Shout out, ask a question, get involved. So a quick word about why immunotherapy. So I think some people on the panel are sick of my analogy, but I love to think of type 1 diabetes as a candle that burns down. So beta cells are the cells, as many of you probably know, that make insulin. And the beta cells, if you think the mass that we start off with in life is like a whole candle, and those people who are genetically susceptible for reasons we still don't understand, that candle goes alight. And that's the immune attack on the beta cells. The autoimmunity that we know of is indicated by the presence of autoantibodies, which actually can now be detected on the simplest of blood tests, actually through a finger prick at home, which John Wentworth can tell us more about later. So as the immune system continues to attack the beta cells, or the candlestick burns down, the body is unable to handle glucose properly, and we have abnormal glucose levels. So that's considered stage 2 type 1 diabetes. And then at the point where we're typically diagnosing diabetes, so when the person's symptomatic and have certain blood glucose levels, that's considered stage 3. But as you can imagine, and as you can see, that candle's nearly burnt out. We really only have 20% of functioning beta cells by that stage. And so ideally, we stop the flame as early as possible in order to keep the person's own insulin production. So insulin injections, even pumps, we know that they're not perfect substitutes for what the body was able to do. So it's best to start treatment when a portion of the person's beta cells are left to preserve. So really, if you can imagine, the earlier, the better. So when we use the term cure, it's often to mean to relieve a person of symptoms or consequences of a disease. And there's really been 2 main strategies in type 1 diabetes. So there has been incredible advances in restoring appropriate insulin secretion through technology, transplantation, and stem cell research. However, in a person with stage 1 or even stage 2 diabetes, where functioning beta cell mass is still adequate, really the aim should be to stop that immune destruction and preserve that own person's beta cell mass, or if you like, to blow out the flame and preserve the person's own candlestick. In fact, even where the disease organ is restored through pancreatic transplantation or the like, we know that the autoimmune attack still needs to be addressed to maintain those functioning beta cells. So really, we want to blow out the flame, stop the autoimmunity, and preserve beta cell function. Now, recent research has identified immunotherapies that suppress this immune attack and preserve beta cells, thereby delaying or decreasing the need for insulin injections. And testing new immunotherapies alone or in combination with proven ones is a logical next step towards prevention and cure of type 1 diabetes. Each clinical trial helps us understand how to best prevent the autoimmune attack, work out who responds to immunotherapy and why they respond, and what dose is optimal. So ATIC's vision is that every Australian with type 1 diabetes has access to immune therapy to achieve this. We have 6 working domains to ensure we work together with the type 1 diabetes community to develop safe and effective immunotherapy that can be incorporated into routine clinical care. So you can see here clinical trials, community engagement, data management, education and training, preclinical and translation, so getting the science into the trials, and regulation and government. So feel free to ask about any of those domains later to the panel, but I'm just going to touch on the clinical trials. So even though ATIC was really only officially launched in August of last year at the Australasian Diabetes Congress, really the trials have been full steam ahead. And just to give you a window into one of the studies, the Bandit study that some of you may have heard of, it's a world first study designed and sponsored by St. Vincent's Institute from Melbourne here, investigating the use of baricitinib in type 1 diabetes. And baricitinib is the first JAK inhibitor to be studied in type 1 in humans. Now, St. Vincent's Institute pioneered animal studies, which found JAK inhibitors stopped the autoimmune attack of beta cells in mice. And so it was the obvious translation to see if that was possible in humans. So they recruited recently diagnosed people with type 1 diabetes between the ages of 10 and 30, was fully recruited in a year, 90 participants, and we're excited to hopefully see some results by the middle of this year. The primary objective being to see whether by 48 weeks of this tablet, which has already been successfully used in rheumatoid arthritis, 48 weeks of it, can it reduce the loss of beta cell function, or C-peptide, which is used as a surrogate in new onset type 1 diabetes. So that's under analysis and recruitment has been completed. But we have now a new study, intranasal insulin and abatacept in recent onset type 1 diabetes. So that's a randomized controlled trial looking at 2 safe immune therapies. So abatacept, again, has been used in rheumatoid arthritis, psoriatic arthritis, and has even already been shown to slow down beta cell destruction in newly onset type 1 diabetes subjects or people. And they've found that, they're testing that whether people on abatacept with nasal insulin will have a more effective response and reduction of beta cell destruction. So everyone gets the abatacept, which is the exciting part. It's either nasal insulin or placebo that will be the difference between the participants. They're looking for about 60 participants between the ages of 6 and 21 with within 100 days of diagnosis. And feel free to go to the website and inquire to find out more, or ask John tonight. So that's currently recruiting. So that's all I have to share. And I would just love to invite Dorota, who actually maybe, yes, I'll invite you first and then introduce everyone else. So this is Dr. Dorota Pawlak, Chief Scientific Officer of JDRF Australia. And we would just love to hear you share with us how ATIC came about.
Thank you so much, Michelle. Can you hear me well?
Yes, thank you.
Fantastic. I just wanted to say what an amazing start to the ATIC. I think there is already making such a difference. For those who maybe have not heard about JDRF before, it's an organization that focuses on research in type 1 diabetes, and 50 years ago, it has been established by parents of children living with type 1 diabetes, and ever since has been focusing on research that in its heart has a mission of creating a world where type 1 diabetes no longer exists. So naturally, building on your presentation, Michelle, it means that we need to find therapies that would offer cure or delay or prevent that destruction of insulin-producing cells from happening. So over the years of the support by us and others who invest in type 1 diabetes research in Australia, we've recognized that there is an extremely high level of capable immunotherapists and clinicians in Australia that contribute not only locally, but also globally with their expertise and knowledge. And also we have a very healthy health system that really supports doing clinical trials, that it's also well recognized internationally and globally respected. So we were building on an enormous expertise and work that already have been happening in Australia. We felt that there were probably gaps that were maybe making it more difficult for the clinicians and researchers to reach their full potential in terms of research, but also from the patient perspective, which was the most important from our perspective, was that to build an opportunity for people living with type 1 diabetes, or those who are at risk, to be able to participate in clinical trials, you have to have a robust ecosystem that allows this to happen. So from coming to this one, we came to a vision that we would like to help out a bit for the research community and create a bit more cohesiveness in the system that would also probably allow much more two-way traffic, so to speak, of amazing Australian opportunities and ideas such as baricitinib to be visible and recognized globally, but also for the international clinical trials that are happening elsewhere to be available to Australian community as well. So it needed a little bit of further funding. So when we were fortunate to have funding from the Australian government, from the federal government, to stimulate research and particularly in clinical trials and therapies in Australia. And as part of this opportunity, we released a call for a national collaborative to be established, in which it would be very patient focused, would build on the current strengths in Australia, would foster building new talent and mentoring for aspiring clinicians and researchers, be very collaborative, sharing, and also very strong involvement from the consumers and from the individuals who live with type 1 diabetes in how they are engaging with the researchers and clinicians. So we were extremely pleased to see response from Tom and John and how they built the collaboration, not only across Australia, but also New Zealand, to create an outstanding proposal, which was robustly reviewed by experts across all the different countries, and who uniformly said it was one of the best proposals they have seen. So we are being assured that, can assure everyone online that it has been extremely competitive process with a lot of endorsement from the best experts in immune therapies globally. So the ATIC is absolutely integral part to creating that vision of the world without type 1 diabetes. And I couldn't be more supportive of your directions, and you've already made such a big difference. And I hope that we can keep building on what your achievements already are.
Thank you so much, Dorota, for all those insights and the encouraging words. So I'm going to go straight into introducing the expert panel members who are all integral to bringing the ATIC vision to life. So please join me in welcoming, in addition to Dorota, Professor Tom Kay, ATIC Chair and Director of St. Vincent's Institute of Medical Research in Melbourne. We have Associate Professor John Wentworth, ATIC Lead Investigator and Endocrinologist at Royal Melbourne Hospital and researcher at Walter and Eliza Hall Institute of Medical Research. We have Ms. Fiona McGregor, Deputy Chair of ATIC Community Engagement Panel. Ms. Kate Wilkinson, Clinical Trial Participant. So feel free to write any questions you like on the Q&A section, because that's probably the only way we have to interact with you at this stage. So to kick us off, I might ask the first question. So Tom, we've heard that you've been involved in type 1 diabetes research and helped to head this proposal to JDRF. So you've been involved for more than 30 years, including establishing the Tom Mandel Islet Transplantation Program in Australia. So I know that SVI and type 1 diabetes research community in general are taking a multi-pronged approach to research. So could you tell us a little bit more about how immunotherapy came to the fore in recent years for the management of type 1 and how you see that fitting into the type 1 treatment landscape?
Okay, thank you very much, Michelle, for the intro, and thanks, Dorota, for your nice words. I'll try to be as quick as I can. I think the bottom line as to where immunotherapy has come from is that our group and other researchers around the world have been studying type 1 diabetes to try and understand it as an autoimmune disease, to try and understand how it works in the body, what goes wrong to cause type 1 diabetes. We would call that the mechanisms of disease of type 1 diabetes, if you like. And people have been studying that ever since it became apparent that type 1 diabetes was an autoimmune disease. And for scientists like our team at St. Vincent's Institute, it's not just about, it's very much, we're very, very interested in discovering new knowledge, but we're also interested in the purpose of that new knowledge. Scientists are interested in discovery, but also application of knowledge. And for all of us, the ultimate goal is to use knowledge to improve patient outcomes, to improve the treatment of diseases in the community. And that, in general, is what medical research is all about. And that's what we've been doing with type 1 diabetes. So our team, including particularly Professor Helen Thomas, and Helen and I have been working together for just on 30 years right now, which is a long time to work closely with somebody. We established that the various pathways were critical in causing diabetes in mice, which mice are sometimes denigrated as not being relevant, but there's some kind of a clue. And so we pursued the possibility that the same pathways might be causing diabetes in humans. And lo and behold, the pharmaceutical industry came up with a drug that blocked the exact pathways that we had worked out were capable of causing diabetes. So it wasn't a stab in the dark to try this drug in people with type 1 diabetes. It was really based on decades of work establishing that we thought it was likely to be effective. And of course, as Michelle said, we will know pretty soon whether that has been the case or not. So fingers crossed. I guess our group is interested in challenging insulin as the sole treatment for diabetes. 100 years of insulin is a long time. We're interested in the thought that there might be treatments that strike at the heart of the mechanism
think we lost.
In the first instance, we think that will add to treatment with insulin. But in the future, as Dorota mentioned, we very much hope that the need for insulin might disappear altogether, and that's going to require things like type 1 screen to identify people very early in the course of the disease. Maybe that's enough of an answer to that question, Michelle.
That's excellent and very comprehensive. Thank you, Tom. We have a couple of questions that I might address. And sorry, Brahim, I didn't realize you wanted to ask another question. So I can read it out for you, but I might allow you to talk, see if that works. So you just need to unmute yourself. No.
Yeah, I was just interested from the point of view of causes and prevention. Is the problem more common in women when they're pregnant, overweight, and or have gestational diabetes, and or have got a history of some immune or autoimmune conditions? And so should we be paying more attention to these people on a preventative basis?
I might direct that question to John, who is involved with weight related research and immunotherapy.
Thanks, Michelle. Thanks, Brian, for the question. I'm not aware of a direct relationship between gestational diabetes, which is more a type 2 diabetes phenotype, and subsequent type 1 diabetes. But I suspect there is probably a small relationship because there would be an inherited predisposition for the child to have a slightly smaller pancreas in a mother who has gestational diabetes. But in terms of type 1 diabetes, really the major maternal risk factor would be if she has diabetes herself, or probably even more important, whether her partner has type 1 diabetes. Because what is fascinating and that we still don't understand is actually with parents who have type 1 diabetes, the child is at much higher risk if the father is affected rather than the mother. There's something about maternal type 1 diabetes that protects the child from getting the disease. But that being said, in families, it's about 10 to 15-fold higher risk than in the general population. And there aren't really that many other features that would further increase that risk. There are some genetic tests that aren't done routinely that perhaps could add to that risk prediction. But a family history of disease is a pretty good metric as to whether your child's going to be at risk of disease. But we also understand that the vast majority of people who are diagnosed don't have a family member with the disease. And to find all of those people, we either have to screen everyone for antibodies at a certain age, or perhaps even do it in a two-stage approach where we first look for the genetic risk, and then those in the high risk category have the antibody tests. And we're still working that out. So I hope that answers that question for you.
Thank you.
Thanks for the question. We have an anonymous question now. Does having clinical trials available in Australia mean that if they are successful, the therapies will be available more quickly than if the trials were overseas? So I'm not sure if Dorota, Tom, or John. Oh, Tom wants to go for this one. Okay, go ahead.
Well, I'm happy to anyone else can chip in. I think it's a good question. I would say that one of the motivations for doing clinical trials, for us all to bring clinical trials to Australia, is the possibility that new drugs will become available more quickly in Australia, at least partly through the clinical trial itself. And I think that's a motivation, not just in type 1 diabetes, but across the board in diseases. At least the drug is in the country being used. You can sign up for a clinical trial and you've got a reasonable chance of receiving the active drug. That's not quite the question that you asked, though. The question, I think, was more about, would that subsequently lead to the registration of that drug in Australia for the indication, more so than if the trial was done overseas. And I would say that it's not obvious that there would be a direct relationship there. We would work hard to bring an effective new drug to the market as quickly as possible, but it's a complicated process with many factors that need to be navigated. And, you know, one of those factors is needing the support of advocates, activating the patient voice, if you like, hearing from the community, and in the future that we will be calling on people to make the case for us with regulatory authorities and so on to help us bring drugs to the market. And of course, the JDRF will play an important role in that.
Thanks, Tom. Dorota, did you want to add something there?
Yeah, no, I agree with Tom, absolutely. And but I also kind of feel that having researchers, and particularly clinicians, researchers, being involved in clinical trials when they get familiar with the new therapies, I think it's an important stage where the drug is being approved by the regulatory bodies, about how familiar those clinicians are with this new medication or therapy, and they can be champions, you know, for this therapy among other clinicians who might not be that up to date with how the field is evolving. So I think it's eventually it does shorten the transition to the new therapy if the drug is available through the research mechanisms. So I think it's an important step. And I think having a collaborative such as ATIC, it also makes the world much more attentive to the capacity of such regulatory approvals to be taking place in Australia. So I think overall it does work together, but it is a very complicated process and not as straightforward as Tom has mentioned.
Can I please make just an added comment there? I mean, I think one key comment is that we can't get anything to the clinic without doing the trials. And I think by having Australia active in that space, we are contributing to the global effort, and we're making very significant contributions. So I think that's important to note, despite these difficulties. But I think it's a massively important question, and it's what everyone asks us. I'd be very interested in Fiona and Kate's response to that as well, because obviously this is, you know, you want it yesterday to be available, and it's very frustrating. And you know, how you know, what does it weigh on your mind when you think about joining a clinical trial, for instance? You know, given that it's going to have to be stopped for safety reasons, and there's got to be time taken to get the answer. Can you talk us through your perspective on that and how you think through that? Because it's a big problem, I think.
I'll go first if that's okay, Kate. So I think if just representing anyone that is either living with or newly diagnosed, or is caring for someone newly diagnosed or throughout their span, is any benefit whatsoever at helping to improve glycemic control or reduce burden is what we'd be interested in the clinical trial, being involved in a clinical trial. So part of what you're making me think of, John, is making sure that we're all informed properly of those risks and of the benefits, which is obviously what you do as a clinical trials investigator with your patients before they decide to go into it. So as long as I've been really well informed and I know what the risks are, perhaps of it having to be stopped for safety reasons, if I've been able to contribute, I may not be on, you know, I could be on the placebo, but for me, being part of a trial is, yes, there could be some benefit for me, but ultimately the benefit is for everyone who is at risk or has type 1. And so that's the way I look at it.
And Kate, yeah, we'd love to hear from you. You took the plunge and got involved in Bandit.
I did, yes. And I completely agree with Fiona. A lot of my reasoning for jumping on board with the Bandit trial was the benefit that would have to the entire community and not just myself, and the potential for change. As someone who is newly diagnosed and, you know, looking at my future and how this was going to affect the rest of my life, if there was something that I could do to potentially change that in my lifetime, I wanted to be part of that, and certainly, you know, try and make that difference.
And while we have you on the spotlight, Kate, what has it been like for you being in a trial?
It's good. It's been good. I think having the trial right while COVID was at its peak as well was an interesting change to format. So a lot of my trial was done remotely, a lot of my work. So the trial is based in Melbourne and I'm based in Geelong, which is about approximately an hour for anyone that's not in Victoria. So I did all of my blood testing at just at a local pathology centre here, and all of the other requirements I did from home, like heart rate, breath rate, those sorts of things, and then submitted all my data back to the trial. For the appointments that I did need to attend at the hospital, they were really easy and accommodating around the timeframes that worked for me because I work full time. And they're all very reassuring, the trial nurses. They talk you through every step of everything. They talk to you about what they're doing, why they're drawing the blood, what they're drawing the blood for, and how it's going to look for you over the time that you're sat in that chair there as well. It was a wonderful first time experience. I think was probably gone the best that it could have.
Sounds great. And yeah, some of the innovations of what happened with lockdown, learning how to do trials remotely has really opened the way for remote people. Yeah, thank you. I have a few questions come in the meantime. Are there any clinical trials for LADA patients on the horizon? So maybe as our clinical trial lead, John, did you want to talk to that?
So for those who don't know what LADA is, LADA, it stands for latent autoimmune diabetes of adults. And I guess we've been not quite sure how to think about it really, but I guess it's a mix of a bit of type 2 diabetes where the pancreas perhaps is not large to start with. There might be a little bit of weight driving it as well, but maybe not. Plus some low-grade immune attack on the pancreas that eventually requires insulin treatment. But initially, at least, patients can get by without insulin, mostly, usually tablets or even just diet alone. And so it's a very slowly progressive disease. And ultimately, immunotherapy is going to be effective for LADA, but LADA is not a suitable type of disease for us to start with because of the long time frames. And when we run trials, we really want to run things as quickly as possible so that we can learn what we can learn. We can't ask too many questions at any one time. We're investing a lot of resources, a lot of people's time. So we need to do things quickly. And for that reason, we are really focusing on people who have an insulin requirement from diagnosis. And we do that because we can see the effects of our therapy much, much more readily. But ultimately, there will be trials for LADA. Unfortunately, right now, I think all we have are observational type studies at Melbourne. There's a registry that's been set up through the Royal Melbourne Hospital, and I'd certainly be happy to provide further information about that. I don't know of other specific trials for LADA, but I could be wrong. There could be others going around in Australia, and maybe we'll see some in the chat pop up as well.
Thanks, John. And if you wanted to get in touch with John, just go through the ATIC website and it can be redirected to John if you've got a question for him. We've got a question from Amy Wright. Hi, I got type 1 diabetes 2 weeks post the COVID vaccine. What is your opinion on the vaccines causing type 1? There's no history of diabetes in my family and I was diagnosed 2 weeks post the vaccine. And that's specifically Pfizer vaccine.
I'll have a quick comment. It's very difficult to know. We haven't seen a signal of type 1 diabetes being really tightly correlated with the vaccine, but of course it is very possible that has been a trigger for your diagnosis. We definitely have seen COVID infection and the stress that places on the body unmask diabetes, and so it's not uncommon for people to be diagnosed after they've been infected with COVID and had a bad inflammatory response to it. But the vaccine, I'm not aware of any firm evidence, but again, it is possible. It's very hard to know, unfortunately.
Thanks, John. We have a question about the intranasal insulin study. So why does the IAA trial use nasal insulin rather than injections?
So the idea behind the nasal insulin is not to lower glucose, because actually the insulin never gets into the bloodstream. It gets taken up by the immune cells in our nose. And that forms part of the gastrointestinal immune system. And the role of that immune system is really to, I guess, tone down immune responses to outside forces like bacteria and bugs and things like that, and try to regulate the response to various things that are thrown at it. And so when we give insulin to the mucosal immune system, so in this case in the nose, we're actually using it to educate the immune system not to attack insulin. And because the primary cause of type 1 diabetes is the immune system going to the pancreatic beta cell, recognizing the insulin as foreign and attacking it, we are very hopeful, based on previous work that we can go into more detail about later, that by adding the nasal insulin, we can add additive immunotherapy, if you like, to tolerize the immune system and turn off that immune attack in combination with the abatacept injections.
Thanks, John. And if you want more information, again, head to our website. We're happy to provide leaflets, flyers, and John also is happy to have a chat with you. So we have a question. Are any of our experts at this forum offering off-label immunotherapy for the newly diagnosed at this time?
So that's Karen McNeil. Hello, Karen, a fellow colleague in Melbourne. No is the short answer, but the longer answer would be, well, we know several things work, and the major barrier is cost, actually, for many of these things. I think we have sufficient trial evidence that a number of therapies would be potentially helpful in certain contexts, most notably teplizumab, which has been approved in the US for people who are at very high risk of developing diabetes, but who don't yet use insulin injections to control blood sugar. So if I had ready access to teplizumab, I would certainly very happily prescribe that to people in that situation. And there are other therapies that I could think about if someone really asked me to give them or prescribe them to them. But now I feel that I will wait and see if we can get some better options for people. And Tom has a comment as well.
Well, my comment is just I'm sure you were thinking this, but just for clarity, and hello, Karen, teplizumab is not registered in Australia, so it's not possible to prescribe teplizumab off-label in Australia, of course, but perhaps in the future it might be. So that's just one addendum to John's comments. I mean, I think it's a valid question that comes up quite a lot. I haven't seen anyone, I'm on the sidelines a bit from a clinical point of view, and I don't see my clinical colleagues who know a lot about this area rushing to prescribe things off-label. I would say I just haven't seen anyone do that, but it may become more of a possibility over the next couple of years. There does seem momentum building to these drugs coming into clinical practice. It seems like we're going through a moment with teplizumab being licensed in the US and positive trial data with other drugs, where there will be opportunities to think about doing what you say, but I don't think it's part of clinical practice at this stage.
I'll just add to that, Tom, that I suspect you could find a mechanism to bring teplizumab in under some sort of special needs program, but the asking price is exorbitant at the moment, and that would be the biggest problem.
I mean, several of the other drugs are not expensive, and definitely I think they will, people will start thinking about this more and more. I think our area, the immunology of diabetes, people working on the immunology of diabetes are very frustrated, for example, that the pharmaceutical industry hasn't followed up some of the positive data in the field, particularly, for example, the trial which we all refer to as the golimumab study, which is a trial of an anti-TNF antibody, which did pretty well in a clinical trial, but the drug company, for its own commercial reasons, I assume, is not progressing with its registration. But that's, for example, as a class of drugs that people could consider using off-label.
Fiona, yep.
I'm just aware that we may have some lay people on the town hall tonight that may not really know much about the immunology side of things. Where can they get more information, for example, about JAK inhibitors and TNF?
That's a really great question. So our website doesn't have the information all already populated yet, but if they reach out to someone through that website, we can definitely provide more information.
Sounds like we've got another web page or two to build, Michelle.
Yeah, I think definitely is an excellent something that we can provide. We've also had some community talks here and there, sort of introducing some of these concepts in more detail, but yeah, to have something more readily available on the website would probably be useful. Thank you. Sorry, were you going to say something, Tom?
I think there's quite a lot about, there's a decent amount of background about the Bandit trial on the Bandit website. That would, but that's not comprehensive of all the sort of drugs that people might be interested in.
Yeah. And we've got another question from Anonymous. Why do therapies that have worked for other autoimmune conditions also work or maybe work for type 1 diabetes? Is there a connection? I feel like that might be Tom's.
Yeah, so I think that that's right. So this is a group of conditions that share mechanisms, and it would be therefore expected that they might be also share therapies. And I think one of the things that JDRF has always encouraged us to do is learn lessons from other conditions, to look at other conditions like rheumatoid arthritis, which is another autoimmune disease, multiple sclerosis and so on. There are exceptions to that. Not all drugs work to the same extent in different, it's not true that they all work the same in different autoimmune diseases. I don't think it's surprising that there are shared pathways, shared ways of damaging the immune system can damage tissue and so on. I think that's expected, and it turns out to be the case.
There's also a question, what is your opinion on type 2 diabetes medications? For example, Jardiance and metformin off-label for type 1s.
Now, this is going to be controversial.
So they have a role. Neither medication is approved for use in type 1 diabetes, but these medications are used very frequently for people who have type 2 diabetes. Metformin, as far as I understand it, acts primarily on the liver to improve its ability to respond to insulin. And it has been helpful to help improve glucose levels to a minor degree in type 1 diabetes. And some people find that they can use it to help lose a little bit of weight, maybe a kilo or two. And it's a very old and safe drug. And we don't, the only reason it might be a problem for type 1 diabetes would be if there are other serious illnesses. Dorota, do you want to comment on that at the moment, or?
Just a bit more general comment that I think that many researchers and clinicians worldwide are a bit frustrated that the clinical trials that using the type of medications that can help potentially for the insulin to work better often do not include people with type 1 diabetes. So they do not really kind of include diverse types of diabetes. So it's sometimes really hard to understand whether it would be useful or not useful. And I think that there is a swelling by different funders to kind of try to change it. So when the clinical trials do start in looking at a particular medication to include diversity of types of diabetes. Otherwise, it takes a very long time to design a trial just specifically using type 1. So actually, it's very, I think, frustrating for clinicians, I'm sure. And I think that a number of funders, including the National Institute of Health in states, are trying to change it. And I think we, as JDRF, as a global family of JDRFs, think it's a kind of a shift in our approach as well, to kind of talk to different funders to start to change it, because that might shed a little bit more light about how those medications can be used and who would benefit more.
I guess, given that I'm no longer a clinically active sort of person, and what I said at the start of the session, and I can see the practical, the empirical, maybe they would help a bit. I see it as a big sort of confusion between, people treating a lot of people with type 2 diabetes and saying, well, this might work for type 1 diabetes. But in my mind, these are extremely different conditions, and they have extremely different mechanisms of disease. So you're going to go down this path that we've been trying to go down on, saying, we've spent, the field spent 50 years trying to understand type 1 diabetes really well. To me, the priority lies with tackling those mechanisms rather than having a stab in the dark with a medication that works for a different condition that happens to share the same name. But that's like an outrageous, non-clinician, non-reasonable thing to say. I'm just throwing it in to be argumentative.
No, I think it's very reasonable to say, if you think this drug is going to work, tell me why, tell me how it's going to work. But I might just segue to the SGLT inhibitors, because that's a minefield in type 1 diabetes. So these tablets have been around for more than a decade. They work by acting on the kidney to make it lose glucose through the urine. And that's incredibly helpful, because it means that because the drugs work best when the sugar levels are very high, and they don't work so well when the sugar levels are normal, it means that the peaks that you would normally get after you eat a meal with type 1 diabetes are much lower. And it also means that because you are peeing out calories, your weight drops off a little bit, and that can offset some of the weight gain associated with insulin treatment. And that's incredibly helpful in overall glucose control. And more recently, we've found that these medications also provide very powerful protection against kidney damage and against heart failure. And that's in type 2 diabetes populations. And so it would make sense that similar sorts of benefits would be delivered to people with type 1 diabetes as well. But the problem, of course, is with these tablets, they increase the risk of ketoacidosis, which is that very nasty condition that occurs when you have an absolute insulin deficiency. Often it occurs when you're diagnosed, you feel terrible, it's an emergency, you often need to be treated in hospital. And the trials that have been done so far, where they've enrolled people with quite established type 1 diabetes, usually a disease duration of about 8 years, have shown that over a year of therapy, 1 in 50 people taking an SGLT inhibitor will end up in hospital needing treatment for this condition. And for that reason, people are a little bit wary of using these medications in type 1 diabetes. Now, I myself I really feel we need to explore the value of these agents in type 1 diabetes more. I think the trials are underway to show that they preserve kidneys and preserve the heart around the world, and that's very important. But my own belief, and I'd love to be able to demonstrate it, is that if we gave these tablets to people early on in their diagnosis, when they can make insulin, their risk of ketoacidosis would therefore be lower. You can take the pressure off the pancreas, and maybe in combination with immunotherapy, obviate the need to use injected insulin to control sugars. And that would make life a lot easier for people. And we've done some early studies that certainly have signals in that right direction as well. Fiona.
Thanks, John. Just to back up what you're saying there, like I'd written down here, prevention is better than cure or current management. So, and that's what essentially ATIC is looking at, is trying to prevent the progression, as Michelle showed in those slides, from going on to that stage 3, where you actually do have those overt symptoms like the high sugar levels, the thirst, needing to wee, losing the weight, and then perhaps having to be admitted with DKA. So I can understand where people are going, well, for those of us that have already got stage 3 and past the 100 days and are on established insulin therapy, there's obviously, we're trying to look at, and I'm speaking on behalf of ATIC here, trying to have to avoid going, can we put this medication that's not even designed for this autoimmune condition that we have, which is type 1, is looking, okay, how can we prevent it to start with, but also keep asking these questions. And that's what I would encourage you all, because they all form research questions if they haven't already been explored, and try to think, how can we prevent those long-term complications, the short-term complications of having low sugar levels or high sugar levels, issues that we all get scared with when, you know, things are not going so well.
Yeah, thank you, Fiona, for that insight. I mean, Kate, did you want to speak to any of your sort of own opinions and off-label use of drugs and how you feel about being able to access or not being able to access certain medication?
Question. It's probably something that I need to do a little bit more research on. I've been fairly new to all of this. I'm still doing a lot of learning. You know, wrapping your head around it initially is a huge learning curve, but then bringing in all of these extra elements is just a whole nother step that you have to work through, one little piece of information at a time. So it's probably not something that I have formed an opinion on yet, but thank you for asking.
Thank you. Yeah, no, it's there is a lot here, because there is even more questions actually. So I might ask for just brief answers to these two, because we don't have a lot of time left. Are there any trials for man-made beta cells? How do I get into a trial on man-made beta cells? I think maybe Tom can speak to this.
Well, to get into currently the only forms of beta cell replacement, putting insulin producing cells, human insulin producing cells back into people in Australia, are pancreas transplant in the context of having a kidney transplant, and islet transplantation for people with very difficult to control diabetes, especially with severe hypoglycemia and hypoglycemia unawareness. What is in early clinical trials in the US are beta cells derived from stem cells, and that will come to Australia, hopefully in the not too distant future, but it's not here right now. And in the US, there've only been a handful of people treated by the main company that's involved in doing that, which is called Vertex.
Thank you.
And Tom, is there anything going on in Australia? There is certainly some early stage research, but I don't believe there are any trials, are there, that are coming anytime soon with beta cell replacement?
There are no stem cell derived beta cell trials that I know of in Australia.
Dorota.
That's right. There is no stem cell research. However, there is a research project that does include human participants with type 1 diabetes that is testing the human-derived cells. However, it's only restricted to individuals who already had transplant, such as like kidney transplant. So at that moment, we are supporting one clinical trial that is being run through Adelaide. But it's still like similar to the stem cells in the very early stages. So it's very few subjects who qualify to participate in it.
Mm. What are considered the possible causes of the autoimmunity? It's a big question. Can someone answer it in 1 minute?
You can answer that, Michelle, but please don't preface it by saying we don't know, because we know a huge amount about that. But why don't you give a snapshot?
Sure, give me the tricky one. Yeah, so there's been multiple hypotheses, some suggestive more than others, but there's been the suggestion of viral infections, suggestion of changes in microbiota. There's been suggestions of drugs itself, and what other, just genetic, but not sure why the trigger happens in certain people with those genetic risks and others who haven't. There's some people who believe beta cell stress whether that's through diet, weight. Anyone want to contribute to the list?
Look, I think the main way I think about this is that the immune system has got this amazing, it goes through this amazing developmental window as it becomes exposed to all the things that are in the outside the uterus. You know, it once at the final stages of pregnancy and as a baby is born, it suddenly encounters the outside world in a massive way. It must be just so full on. The process of being born and the process of the first few months of life. And that is a massive stimulus to the immune system. And in people with genetic susceptibility, some aspect of that that leads to cells being born that have got the capacity to damage the beta cell or other cells in other autoimmune diseases. And in certain people, under certain environmental circumstances, that turns into type 1 diabetes. I guess the main thing we know, and this comes back to the question about the vaccines earlier, we know that the majority of people have the onset of that autoimmune attack, your candle is lit very early in life, within the first year or two of life. So it's something to do with this explosion of the immune system as it deals with the outside world, and this birth of some lymphocytes which do the wrong thing. That's the way I conceptualize it.
And then to add to that question about sort of interaction between other autoimmune conditions, interestingly, type 1 doesn't have a female predominance and happens very early in life compared to a lot of autoimmune conditions which happen a bit later and are often more common in females. So it's a lot of interesting parts of the equation. What are the experts' thoughts about type 1 as a different disease to type 2, being a metabolic disease? Can type 1s also have metabolic disease that drugs like Ozempic, metformin be helpful in treating? So that's sort of, I think John touched on that already a bit, but do you want to wrap that up, John?
Yeah, so Ozempic is sort of the big poster child of type 2 diabetes at the moment, and it is a medication that mimics a natural hormone that all of us make when we eat. It comes from the bowel, it goes around the blood to the center of the brain and tells us we've had something to eat and we don't need to eat anymore. And so they've developed a drug based on that molecule that can be there at a very low level to provide fairly constant appetite suppression. And that's incredibly helpful in type 2 diabetes, particularly when weight loss is going to be effective as a way of managing the blood sugars. Now, in type 1 diabetes, of course, being overweight or obese is actually not uncommon. And the insulin therapy that we use to very tightly control glucose can often drive a bit of that weight gain. So I think there is certainly a place for this drug in the treatment of type 1 diabetes. The big problem we have is that the federal government feels it should only be used for type 2 diabetes. And I don't necessarily think that's right. And we kind of find ways around that that I won't discuss publicly. And so it does have a place, primarily to help with a little bit of weight loss that in turn will help improve glucose control. I think there are probably going to be other benefits. There are, of course, side effects, primarily around tummy upset and nausea and things, but it has a role. And I think there'll be a lot more research done in a clinical trial context to define exactly how we should use it for people with type 1 diabetes.
Thanks, John. So we've hit time, sorry, Bram, and a couple of other questions that haven't been answered yet. I'm going to direct you guys to ATIC at svi.edu.au or ATIC, the ATIC website. Just email us. We're happy to respond, put it all in the Q&A mail out that we will ensure goes on the website. And this will be all recorded, so you can look back at that or share that later. If you think you're eligible for the IAA trial, the intranasal insulin abatacept trial, just get in touch with us through the website as well. Follow us on Facebook, LinkedIn, Twitter. You'll get all the updates there. I just love to thank each of the panel, so Dorota, Fiona, John, Kate and Tom for your time, your expertise and your opinion. It's really been a very informative session. I'd love to, because we didn't get to hear so much from Kate actually, I'd love just for you to say a last word of if anyone's on the fence of joining a trial or not sure what it's about, what would you say to someone who's sort of uncertain?
It's a big consideration, it is, but so much good can come from it, and for me, it's been absolutely worth it. And I think for a lot of people that have finished up in the Bandit trial would probably be sitting in the same boat as me, knowing that hopefully we've had some really successful results out of this trial, and there will be change and help move everything forward, make a difference.
Well said, thank you. All right, I'm going to end the session now. Thank you everyone for your time and for joining.
Thank you very
Thanks,
much.
everyone.